A warm welcome to today's talk. It's Thursday the 23rd of September. Now I want to look back at a pandemic of the past and compare how we're doing now with the pandemic of 1918, 1919. I also want to look a bit about vaccine and medicine safety. We'll be looking at some fairly definitive data on that. But let's start off with some orientation slides because it looks like, it's a bit early to say, but it looks like the peak of the Delta variant in the United States may, and a stress may have been reached. This is what we're hoping for. So let's look at some data on this. The cases in the United States have been going down now, as we see, for a little while. So here we have Israel, because we know there's a lot of cases there, of course. So Israel's still highest, but going down. Then the United Kingdom, which I'm afraid is going up. But the United States has been going down now for about 7 days, and it's the lowest it's been for some months in the United States. So that is encouraging. Ireland going up, Canada, well, you decide on Canada, levelish perhaps, Australia levelish, India remaining low as we looked at yesterday, and New Zealand thankfully low as well. So some interesting trends going on there and signs of hope in the United States. Still concerned about the autumn in the United Kingdom and the United States. The weather's just starting to get a bit cooler now, so we've got a bit to go on this, but it's looking slightly promising for the States at the moment. So let's hope that bears up. Now, this is the R values that we look at from time to time. So I'm going to just zoom into this a bit because this here is an R value of 1. So what this means is anyone above this, the rate of cases are increasing. Anything below this, it's decreasing. So Canada, Australia, the United Kingdom, all increasing at the moment because they're above 1. Israel, India, Ireland, New Zealand, and just the United States currently going down as they have a value of just below an R value of 1. So we'll be keeping an eye on it, obviously, but it's looking a bit more hopeful there. Now, these are the variants, of course. Now, we kind of know this story already. New Zealand, Australia, United States, India, United Kingdom, Canada, all virtually exclusively Delta variant, apart from a little bit of, I think that's a little bit of Gamma variant there in Canada. Now, the reason I'm showing this is we have looked from time to time at different variants. The Mu variant, for example, which reared its head recently. And some of the concerns about these new variants were that they would lead to vaccine immune escape. And if they became more prevalent, then the efficacy of the vaccines would go down. But you could almost say this is a good thing about the Delta variant. Basically, the Delta variant has outcompeted everything else. It is so transmissible. So there is an evolutionary advantage of the Mu variant by being somewhat more resistant to vaccine immunity. But that is just completely swamped by the massively increased transmissibility of the Delta variant. So we're not saying the Delta variant's a good thing, but it is causing lots of people to become immune very quickly. And it's keeping out other variants that quite honestly would rather not have, because it is so dominant and so transmissible. And as we see, basically 100% virtually everywhere. And this is true all around the world. So you can take that as good news or bad news. There's probably aspects of good news in that for sure. Patient hospitalizations, again, per million. So the United States, thankfully, we see the rate of hospitalizations is starting to go down gradually. But this still belies a very unequal picture in the United States, with some places really struggling still for hospitalised places, other states not so bad. So very mixed picture, and we have looked at individual states before. Hospitalisations, Israel, United Kingdom, Ireland going down, Canada, I'm afraid, going up. So that's the current trends regards hospitalisation. Now, this next one is the level of vaccination. So we have Ireland, Canada, United Kingdom, Israel near the top. So United Kingdom has been jumped, if you like, by Canada and Ireland, which I'm pleased to see they're high. Israel, if we'd looked at the total number of vaccine doses in Israel, this would be higher than all, but these are the number of people doubly vaccinated in Israel, which isn't that high compared to these other countries. Now, the number of overall vaccines given out in Israel is higher because they've given a lot of booster doses out, and we're going to look some data from that in a minute. But that's where we are there. The United States going up, but not as quickly as we would like. Australia and New Zealand both going up quickly, which is good. India, well, not going up particularly quickly, although, of course, they are dealing with remarkably large numbers of the population. And bear in mind, this is for people that are currently doubly vaccinated. So that's just a few sort of trends. I do find these sort of orientation trends quite useful. Now let's get on to the main content for today. US deaths more than 1918. Now, of course, the 1918-1919 pandemic was the last huge pandemic in humanity, really. I mean, well, I suppose you could count HIV as a pandemic, but that was sort of more slow motion, so it didn't quite feel the same. It happened more slowly. Tuberculosis, of course, you could count that as a bit of a pandemic as well. Diabetes, non-communicable diseases. When you keep thinking about it, you come up with more possible examples. But the last sort of infectious disease. So here we have US deaths more than 1918-1919 pandemic, a sad milestone. Now, this was the H1N1 virus, and the genes were certainly avian. So this probably came from chickens in the United States. That is the most likely. I've actually looked at this quite a bit, and there's quite a few conflicting theories, but chickens in the United States looks the most likely culprit for where this made the spillover, the jump from chickens into humans, where it probably occurred. First identified in the military in spring of 1918, 1/3 of the world's population became infected. Now, this is another interesting parallel. I suspect that basically everyone in the world is going to become infected with Delta variant. So I think more people overall in the world are going to be infected. Of course, people travel around the world now. It can happen more quickly, but the Delta variant is more transmissible than the H1N1, a lot more transmissible than the H1N1, as we've looked at before. If I could probably just have a quick look at that now. Here's the infectivity here. So here's Spanish flu, that's the H1N1. And this is more deadly here, so we see it's more deadly, quite a lot more deadly than SARS coronavirus 2 Delta variant. But we do see that spreads faster. So the Spanish flu is there, going along that axis there, we come to the Delta variant. We see that the Delta variant is more transmissible than the Spanish flu, the 1918-1919 pandemic. So it's still looking likely that most people in the world will probably be infected with Delta variant at some stage. Global deaths in 1918, at least 50 million. US deaths were 675,000. Now, CDC says the current deaths from the 2021 or from the COVID-19 pandemic, 666,000. But the actual number, Johns Hopkins gives a more up-to-date number, 681,199. So we see that grim milestone really has been surpassed. So in the United States, COVID-19 has killed more than H1N1 in 1918-1919 in terms of number of people dying. And of course, people are still dying. So the difference is going to become even greater. Now, way back in January even, 2020, I was talking about comparisons between this pandemic. This is before it was, way months before the WHO called a pandemic, of course. Comparisons between this current one and the 1918-19 pandemic, because I could see the parallels were developing, and I was quite widely castigated then for alarmism, but unfortunately it's turned out to be the case, and more people have now died in the States from this pandemic than the 1918-19 pandemic. Now, to be fair, the percentage of the population, of course, is way less because there's 3 times more people in the United States now, but that doesn't take away from the number of individual tragedies. Now, the pandemic subsided in 1919. Officially, the last wave was in 1919, but it carried on circulating all the way through to 1957, when another flu virus dramatically took over. So seasonal outbreaks of H1N1 for the next 38 years. Is this going to say something about the future of SARS coronavirus 2? Well, I suspect there will be seasonal outbreaks for quite a few years to come. Still hopeful the virus can be eliminated, but for the next foreseeable future, really, quite a few years to come, there is going to be seasonal spread of SARS coronavirus 2, and of course, a lot of the world it hasn't got to yet. Mortality in 1918-19. Now, there's big differences. In 1918-19, lots of young children were killed. Terrible tragedy. High death rate under the age of 5. Also high death rate between 20 and 40 years of age and over 65. So strangely, people in the 50s and early 60s weren't so badly affected. So what was going on here is that young people have a more active immune system, and they got this inflammatory reaction to the virus, just the same as is happening with the SARS coronavirus 2. When most people are hospitalised, it's not the actual virus itself, it's the body's inflammatory reaction, this cytokine storm to the virus that was killing people. And of course, also in 1918-19, there was a lot of bacterial secondary infection. So no vaccines at all in 1918-19. The first influenza vaccine was actually experimented on with they just took some dead virus, sort of mushed it up and injected that in British soldiers in the 1930s with some efficacy. But there wasn't widespread influenza vaccines until well into the 1940s. Late 1940s, I think. So there was no vaccine at all in 1918-19, and no antibiotics. So again, tragically, young people were dying of bacterial pneumonia. In the UK in 1918, it was 228,000 deaths. 2021, that is the number of deaths within 28 days of a diagnosis. That is the number of deaths where COVID-19 is mentioned on the death certificate. So we can still see in the UK that even taking the higher estimate, thankfully the deaths in 2019, 2020, 2021 have not yet reached, hopefully won't reach the level that they were in the 1918 pandemic. Global infection fatality rate in 1918-19 was probably 10 to 20% of people that got it actually died. And it's just a pity that so many of the lessons that were learned at such a high cost in 1918-19 had been forgotten about by the time we got to 2019, 100 years later. Human beings seem to have short memories. Now, moving on to the FDA in the United States, Food and Drug Administration, authorised a Pfizer booster for 65 and older. They've got a green light on that much quicker than I was expecting. I wasn't expecting this till next week. People 18 through to 64 at higher risk of severe illness also going to be vaccinated, and those with so-called frequent institutional or occupational exposure. At least 6 months after the second dose. Now, in the UK, it's going to be at least 8 months. I must say the UK approach does seem better with the longer gap and at least 8 months after the second dose of the vaccine, but this is what the FDA has passed pretty well exactly as their committee suggested. They haven't done many changes. So they're issuing emergency clearance. FDA Commissioner Janet Woodcock clarifying on the institutional and occupational exposure bit. Healthcare workers, teachers and daycare staff, grocery workers, homeless shelters or prisoners, or people working in prisons. Both prisoners and people working in prisons are greater at risk. And it's interesting to see they've included grocery workers there because, as I've said before, grocery workers are some of the unsung heroes of this pandemic. They kept working through all of the waves that we could be supplied with groceries. So just maybe say thank you to your grocery worker next time you're in the supermarket or wherever you shop. They've done a good job in this pandemic, and very, very little credit for it, so I give them credit now. Centres for Disease Control and Prevention must still make precise recommendations. That should come in the next day or two, I would hope. They're saying that the key goal of boosters is prevention of serious disease, not prevention of mild infection. Now, there's debate about this, because people with mild infection often need to isolate, and that has a big impact on the workforce. But basically, prevention of severe illness is the aim of vaccination. So I'm happy to go along with that, at least as the priority. Now, one of the things that's a bit delayed in the States, really, is there going to be a Pfizer booster for people who've had the vaccine with Moderna or Johnson & Johnson? We don't know yet. Or there is some provisional data that says people that have had Johnson & Johnson, Janssen vaccine, get really, really good immunity if they have another dose of the same vaccine. Now, the the authorities in the United States really need to get their act together on this now, because it's causing a lot of confusion. So the booster doses are starting, but only for people that had the Pfizer initially. The people that had the Moderna and the Johnson & Johnson need clarity. And now, to be fair, they should get it in the next few days. In fact, this could come come tomorrow. It certainly shouldn't be any later than early next week. So there will be clarity on that. And the recommendations from the FDA, I am sure, will be that there'll be some form of booster for the same at-risk people over 65 and high-risk people who've had the Moderna or the Johnson & Johnson. The question is, what will they be getting? The way I understand immunity, I don't see it makes too much difference. I think any vaccine will give a booster, but there is an interesting data that a second Johnson & Johnson after a first Johnson & Johnson gives particularly high levels of immunity. So it'll be interesting to see which way they go on that. We simply don't know yet, but it shouldn't be long. Now, having said that, this is a direct quote from the CDC site, I think. 2.3 million people in the United States have actually had an additional dose already since the 13th of August 2021. Now, some of these, it's official, people with cancers and severe immunosuppression. Others apparently have been advised by their doctor just to go along and get a third one. Other people have just snuck in on the QT and got one. And it's very hard to regulate this. So people that have kind of wanted one have been able to get an unofficial one so far, and that's so. Probably about 300,000 of those are people that are officially getting the boosters. Maybe about 2 million, just to have a wild guess, of people that have just decided to give themselves an extra dose. So individuals taking it upon themselves, which, to be honest, isn't really quite ideal. These things should be fully organised by the requisite authorities, really. Fewer side effects after the third dose of the mRNA vaccines compared with the second dose. Interesting. Now, this, I'm going to give some interesting data on this in a minute, but let's just look at some of the background here. COVID-19 Vaccine Safety Technical Working Group. Assessment of third dose safety and data. Now, a lot of this information on this PowerPoint, it is a PowerPoint from this grouping, but it's by these reputable people who are in charge of this. This is a CDC reference there, so click on that and it'll take you straight to the PowerPoint. You can look through it all for yourself. Fewer side effects after the third dose. Now, this is the mRNA vaccines they're saying, but of course in Israel they've only been using the Pfizer vaccine. But it's Israel data that they're quoting, so let's look at that. So Israel, third dose, booster doses, about 2.8 million booster doses have been given in Israel. Anyone over 12 years of age is eligible, but most of the people that have had it are over the age of 60, so most of them are older. Fewer younger people have had it, and we know that the likelihood of the particular side effect that we're worried about with this, the heart inflammation, is more common in the younger people, but more older people in Israel have been given the vaccines. But the data from Israel showing rates of reported systemic, local, neurological, allergic and other reactions were substantially lower after the third dose than after the first and the second dose previously. Now, this PowerPoint is talking about mRNA vaccines, but Israel is just based on the Pfizer, so there seems to be some extrapolation going on there. But overall in Israel, 1,000, so it's 2.8 million booster doses. Of that, from those, 1,328 non-serious side effects, 19 serious adverse events, 7 possibly associated with the vaccine. So more than, way less rather than with the other doses. Now here's the data that they give on that's on this PowerPoint. So what we see here is side effects after the first dose. These are the age groups, male, female. So we see the level of, let's look at the myocarditis cases. So we see the myocarditis cases is more common in males than females. And this is one reason that we've suggested that it might be worth regulatory bodies thinking about giving young men an adenovirus vector vaccine, but there's been nothing said on that. But anyway, that was the first dose there. Second dose, of course, we know that these side effects are more common. Again, we notice they're more common in men than in women in terms of myocarditis. So these are the age groups. Again here, younger age groups primarily, of course, and they are the numbers after the second dose. Compared to the numbers after the first dose, a fairly big difference there. But we notice that these are in these younger age groups largely. Now, this is the third dose here. So that's the first dose, that's the second dose. The third dose is here from the Israeli data. So these are the numbers vaccinated, females in the age groups, males in the age groups. And myocarditis cases after the third dose, they are saying no cases observed. Now, this is interesting. It's not quite what we would have expected. And if accurate, is remarkably encouraging news. So it looks like low levels of myocarditis after the first, but enough to bear in mind. High levels after the second, and none observed after the, and that's after 1.2 million doses of booster. Not the full 2.8 million from Israel, but a large chunk of that data. So interesting. Can't really explain that, but that is what the data is showing. So severe side effects appear to be less common after the third dose, which would encourage me as an individual to get a third dose, to be quite honest. Now, I want to look at vaccine and drug safety now. Now, let's bit of background here first of all. So this is the Uppsala Monitoring Centre. Now, Uppsala is the town in Sweden where this was first started. I'm pretty sure it's Sweden, Uppsala. So this is where the working group originally met. So it's called the Uppsala Monitoring Centre. Been taken on by the World Health Organization Collaborating Centre for International Drug Monitoring. So a pretty well set up, sophisticated way of measuring the safety of medicines and vaccines. Check out the link for yourself. Of course, I always put those in. So this is called Vigibase, which is short for pharmacovigilance, keeping an eye on drugs. So this is not clinical trials. This is looking at drugs' safety after they've been released, after phase 3 clinical trials. So you could say this is kind of an ongoing phase 4 clinical trial, really, post-marketing data. Now, you can access it there yourself. Anyone can access this. This is public domain. It's an excellent resource, and you can put in whatever medicine you like. So I just put a few in. So here's one I looked at here. Rarity. I still can't say that word. That's the Pfizer vaccine as marketed in the States. But anyway, what happens is with this database, you put in any COVID-19 vaccine, and what it does is it gives you the data for all COVID-19 vaccines. So this is data for all COVID-19 vaccines. So for all COVID-19 vaccines given out in the world, the result is presented for the active ingredients, which is COVID-19 vaccine. So all of the COVID-19 vaccines, whether it's adenovirus vector or RNA or messenger RNA or whatever. Anyway, total there's been, I need to put commas in, over 2 million total records retrieved of adverse events and side effects. So a pretty high number. Now go on there. It gives you so much information. I'm not going to go through it all on a video, but do check it out. Just click on the link for yourself and say anyone can access it. Now another common drug, amoxicillin. Must have given out thousands of capsules of amoxicillin over the years. Common antibiotic. So this contains the active ingredient amoxicillin, obviously. Total number of retrieved of adverse events, 135,960, just to give another example. Now, the drug we were looking at yesterday, ivermectin. Now, bear in mind, ivermectin has been given to 3.7 billion people, or 3.7 billion doses, probably 3.7 billion doses as far as we know have been given. And that has received 5,648 reports of side effects and adverse reactions, which, as far as I know, makes ivermectin one of the least reported drugs in terms of side effects and adverse reactions there is. I'll have to look through some more and see if I can find any lower than that, but have a look yourself and you'll struggle to find lower than that. So that makes that look pretty safe. Amoxicillin, well, 135,000, we use it all the time. But there seems to be more adverse reactions reported from vaccination, but vaccination is the policy we are following and is the way to produce long-term immunity. So there we go. I thought that was interesting. I warn you, if you go on there, you'll be looking up every drug you've ever thought of. It is pretty interesting, actually. So that's us for today. I think erratum, first of all, made a mess up yesterday, just for a change. So correction from yesterday. I was talking about the government in Uttar Pradesh. Yes, it was Uttar Pradesh, giving out 50 lakh medical kits. And a lakh is 100,000, so of course that is 5 million. Not 500,000, as I wrongly said. So there we go. Sorry about that. Mathematical error. It should be 5 million, which is a lot of kits, of course, to give out in Uttar Pradesh. And we saw that was correlated with interesting reductions in the number of cases in Uttar Pradesh. So that's us for today. I think we'll just... Wefwafwa's just sent an interesting series of videos, actually. I think I'll just introduce you to one of them. There's a boy that we looked at before that Wefwafwa's following up, who's had a fracture and infection in his bone. So it's very, very, very difficult to treat. Now, just to reassure you on the ethics of this, Wefwafwa's given permission to show these videos. Ben, the boy himself, has given permission for the videos, and both his parents have given permission. So there are full permissions there. So we're not doing anything that the family doesn't want to be publicised. So let's have a quick sketch of that video now, and then I'll put a link in if you want to look at Wefwafwa's site or make a donation to Wefwafwa's work, as he does community health work in Uganda.
Hello guys, welcome to our channel. This is Wefwafwa Andrew, and today we are still on our community follow-up program. While we were leaving Mama Wegosaza's place, she told us that there was someone who needed our help within this community, and that's why we are here to see if we can be able to help this young man. Now we are going to get information from the boy and the mother, and we shall be able to know what is exactly happening in this place. So make sure that you stick around as we as I interact with them.
Hello friends, once again welcome back to our channel. For those of you who are new here, on this channel we share medical videos. Sometimes I upload some music, and I also upload COVID-19 updates and community outreach videos. This is because I'm passionate about empowering the community with knowledge such that they can make smart decisions about their health. Now, it has been a while since I last uploaded. This is because I've been in a community, like extremely busy, trying to take the boy you're seeing in this video to meet the orthopedic surgeon, as you will see in the videos that I will upload in future. So this was part of our community outreach video. Actually, on that day, we had gone to visit the mama you're seeing in this video, the one who was carrying that stand. But after making a follow-up visit, after visiting her, she told us that there was a boy who was in a community who needed our help, and that's why we went to check on him, and that was day one of visiting the boy you're seeing in the video. So in this video, I started by creating a report, which is the first thing we should always do when we are interacting with the people who don't know us, most especially health workers. It is always important to, create a report, interact with people, to let them feel free with you, such that they give you the necessary information that you need in order to help them. So that is what I was doing here basically, and after that I started interacting with the mother, trying to get the history of the presenting complaint, such that we can be in a better position of helping the young boy. So she told me that the complaint of this boy started way back in 2018, while the boy was staying in the village with the grandmother. So I was also told that this young man lost the mother some few years ago. So the condition started when he was staying with the grandmother, the mother to the mother of the boy. I don't know how, if that is clear, but that is when it started way back in 2018. That means this boy has stayed in this condition for about 3 years. 3 years of pain. That is what this young man has been enduring. So that is what she told me. She told me that they started like wounds and they drained a lot of pus. They went to the hospital or a clinic. This boy was treated, but they told me that they reached a time when they never had money to treat this young boy. So what they decided, since they were not having, they came back home. And that is how the boy has been staying at home with that problem. I also tried to obtain some history from the boy concerning the condition, and he told me that his condition started when he fell down while in the village. He was carrying that a banana on the head. So he fell down, and that is where it started from, because he was staying in a hilly place. So he was carrying, and it was heavy maybe, and he fell down. So that is where it started from. On the x-ray that we did, it shows that this boy had a fracture at one time, but it was not attended to. So probably that is where the problem started from. But you will be seeing the details in the videos that I'm going to be uploading. For now, I'm just giving you, this is just like part one, because this is the first video that I shoot when we went to the village for the follow-up. We had not actually gone to visit this boy. We had gone to visit a certain mama, but then they called us that there is someone who needed to be seen by us, and we were trying to interact with him. So that was the first video, but most of the things we've done them now, you will be seeing them in the videos that I will be uploading maybe starting from tomorrow. So the boy shared with me a lot of challenges that he's passing through, though I'm still getting more, because as you can see, he was having pain on the leg, but his appearance generally shows that he's malnourished a bit. And when I checked the conjunctiva, there was also some pallor. So that means anemia is either there or is setting. So, and he also told me that he passes through a lot of pain during night and day, and also because the flies are ever on him because of dirty pus that keeps like wetting his pants. So he finds it difficult playing with the friends, because when you have that pus, your friends cannot easily interact with you. So I decided to remove the dirty clothing that covered his wounds with, because they can introduce infection. and I just tried to clean around the wound, and I removed the sandpass that was near, and I covered the leg with some clean dressings. What I wanted first was to take this boy to meet the orthopedic surgeon before we can continue doing other things.
Okay, we're going to
So
leave that
as you can
there.
see,
Yeah, good. We'll leave that there for now. Now you can watch the whole video on the link. I've stopped it there because I'm not quite sure what will we be able to show on this video. Now let me just show you what the background here is. I just love the way Wefwafwa works. It's such a logical, progressive way that it works. Now, where am I? Yeah, there we go. So now, first of all, when Wefwafwa says report, he means rapport, which of course is right. Now, the mum's actually died, so this is grandmother that's looking after him. He's had this condition for 3 years. Now, Wefwafwa mentioned pallor and anemia there. So ideally, when you want to know what someone's haemoglobin is, you would send a blood sample away for haemoglobin. But a rough and ready test is you can look under the conjunctiva there, which so I don't know if you can see mine, but you can see the level of redness there in the inside of the eyelid, in the conjunctiva. So once you've looked at a few thousand of these, as Wefwafwa has, you can start to get an idea if there's pallor. Pallor means paleness. It means there's not enough iron in the blood, so the blood isn't red enough, basically. So you can get an indication from that. And if you haven't got a ready available blood test, that's a good way to do it. Now what happened is actually this boy fell over. Now when I was doing that, I just sketched myself a femur here. So that's the head of the femur that goes into the hip joint. Now what you have inside bones here is you have like a hard bone on the outside called compact bone. On the outside like that. That's very hard compacted bone. But inside the bone, so that's hard bone. That gives a lot of strength and rigidity to the bone. But inside the bone, you have a medullary cavity with a fibrous type of bone in it as well. It's almost like a honeycomb of bony bits. But inside there you have, well, particularly what you have in long bones is at the top here. At the top here you'll have you'll have red bone marrow at the top that produces red blood cells, and you'll have red bone marrow at the bottom there as well. I was just looking for a yellow pen, but I can't find one, so I'll use a green one. But what you've got in the middle here is that there's a lot of fatty material in here as well. So one of the ways that fat is stored. That's why people sometimes eat bone marrow, of course, from animals, because it's nutritious. But what happens is you've got this cavity, so this is the cortical bone here, and you've got this medullary cavity on the inside. But this is all one cavity. It's all one cavity. It's not compartmentalized, which is a bit of a problem, especially in a large bone like the femur. Because what happens is, if you get infection, so what happened is this boy broke the bone. Now, it wasn't an open fracture. Part of the bone wasn't sticking out the skin, but he broke the bone. And when he broke the bone, what happened is some bacteria from the blood, it's called hematogenic spread, got into the fracture and got through the cortical bone into the inside of the bone. So what happened was he actually ended up with some bacteria inside the medullary cavity there. Now the problem with that is once it's inside the medullary cavity, the bacterial infection can spread up the way, which it did in this case. In fact, it spread all the way up there, and it also spreads down the way, because it's all one cavity, all one continuous surface. And this is called osteomyelitis. And the trouble with this is it's very difficult to treat. Now, you can give antibiotics, and when you give antibiotics, you can give tons of antibiotics, and they go into the blood. They go into the blood, and the bones, of course, have an exquisite blood supply. There's lots of blood goes through the bones, but the antibiotic won't leave the blood vessels going through the bone to go into the bone itself. So antibiotics do not diffuse into bone. So when you have an infection in a bone, when you have osteomyelitis, you can't get rid of the infection because it's because the infection is in the bone, and you can't give antibiotics because the antibiotics don't diffuse into the bone, although frustratingly they go through the blood supply in the bone. So I used to assist on orthopaedic theatre. So what we used to do in orthopaedic theatre, this is a few years ago when I worked there, the surgeons had put in antibiotic beads, and you'd sort of pull these out one every few days, so antibiotics diffused into the bone. But that's quite a sophisticated surgical procedure, and I don't think whether the orthopaedic surgeon will be able to sort this out for this boy or not, I don't know. So osteomyelitis is a real problem. And I remember when I was a student addressing, this was probably in about 1980, and I used to address the a femur. I had a patient, a man who had osteomyelitis, and he'd sustained that injury from shrapnel just a few days after D-Day. So work it out for yourself. What is it? 35 years. He'd had this chronic osteomyelitis for 35 years, and that's the problem with this boy. So it's difficult to treat. Anyway, so that's what that's about. If you find that interesting, do click on the site and watch the whole thing, and do feel completely free to donate to Wefwafwa's work as well. He's got all sorts of projects going on, and there you go. Community health is a very cost-effective way to practice healthcare. Anyway, that's gone on a bit longer than I meant to, but there we go. Hope that was interesting, and thank you for watching.